Welcome back to Learn Neuroradiology, everyone. My name is Brent Weinberg. I'm happy to welcome you back to see this fifth part of our lecture on spine tumors, where we're going to cover extradural lesions. These are lesions that occur outside of the thecal sac. If you haven't seen the previous lectures, feel free to go back and check those out at any time, either before or after you check out this video. And be sure to go and check out the rest of the videos on the site as well. Today we're going to talk about extradural lesions. Like I said, those are the ones that occur outside of the thecal sac. It's useful if you think about this quote, the whole world is extradural. So everything that's not in the thecal sac is extradural. So that includes a lot of the common structures that are nearby, meaning the discs, the bones. So think about the common things that affects those things. Infection, disc protrusions, these are very common. In the bones, think about metastatic disease, lymphoma, primary bone tumors. The meninges, so the dura themselves, like so meningiomas, for instance, can have extradural components. The nerves, so you can have nerve lesions such as schwannomas, neurofibromas. These are the lesions we collectively refer to as nerve sheath tumors. And think about blood vessel abnormalities as well, like epidural hematoma, so vascular things, or vascular malformations such as dural fistulas and things like that. Now here on the right, you see our diagram from the beginning of this lecture. When you're thinking about extradural lesions, think about things that are outside the dura, can cause mass effect on the dura, deflecting it to one side, potentially having mass effect on the spinal cord as well. When you look at that on an axial image, this is what it may look like. You may see this dark line of the dura. You may see the spinal cord deflected to one side. These are the classic findings of extradural lesions. Now, extradural lesions are often differential lesions, meaning that you may not be able to provide an exact diagnosis. You may have to have a biopsy. However, there are a couple of things that you can use to hone your differential diagnosis. Think about using a CT, particularly if you're looking at a bone lesion. Think about using diffusion to see if there are densely cellular material, such as a tumor or lymphoma. This can be quite helpful. So we're going to start with a mix of cases here. This is the first case I'm going to show you. This is a case of a disc extrusion. So this is a 56-year-old woman who's had prior spine surgery. You can see evidence of the spine surgery here. You have this big laminectomy defect. And then in the ventral epidural space, what you have here is you have a mass-like lesion. Here you see it on T2. It's kind of T2 iso-intense to the bone, perhaps. On T1, you see it's very similar to the disc. It looks like it's contiguous with the disc here. On post-contrast, what you'll see is you have some peripheral enhancement, a little bit of nodular enhancement. And so the clues that you're seeing here is it's connected to the disc. On T1, it's very similar to the disc, and it looks like it's this extrusion here. This is the classic appearance of a disc extrusion. Now, don't worry too much if they're enhancing. You can see particularly peripheral enhancement, although you see in this case, even the enhancement is a little bit nodular. So just don't worry about that too much. Be careful because these can definitely mimic tumors. So I see these called schwannomas and meningiomas not infrequently. Just remember that they're really common. So think about those if you see something contiguous with the disc in a patient that has bad degenerative changes or evidence of prior surgery. Here we have a second case. This is a 25-year-old with a lesion in T12. It looks like they have this pathologic fracture. Here we see on T2, we have a T2 hyperintense lesion. This is fat suppressed, so you see it sort of outlined here in the T12 vertebral body, extending into the pedicles and posterior elements. You see some height loss of that vertebral body. On post-contrast imaging, what you see is avid enhancement of that, the similar regions. It's definitely an enhancing lesion. Axial images through that area show enhancement of the pedicles, heterogeneous enhancement of the vertebral body, and enhancement of the surrounding soft tissues. So it's concerning that you have a pathologic fracture here and that this is not a typical insufficiency fracture. Now, a useful study that you might recommend, or what you might be thinking about, again, is anytime you have a bone lesion, think about getting a CT to see what those bone abnormalities look like on CT. So here's our CT, and in this case, which is ultimately going to be a case of lymphoma, you see that there are lytic areas throughout the bone. You see areas of loss of cortex and cortical destruction, a lot of sclerosis like mixed with lysis. This is definitely not something which is classic for a hemangioma, so it definitely isn't something that you would want to just directly call a hemangioma or a benign vascular malformation. This was biopsy proven to be lymphoma. So as I said before, CT can really be helpful in further characterizing these bone lesions. So anytime you see a bone lesion, think about following up with a CT. Now, when you do have a bone lesion, you might think about different kinds of patterns of calcification and bone destruction. Here are a couple of examples which may help you through that. This is the case of lymphoma that we just saw. You see heterogeneous patchy areas of lytic destruction, maybe some sclerosis. This second image right here shows a classic pattern for vascular malformation or benign hemangioma. They typically have this kind of stippled pattern where you see a few trabecula that are thickened and they remain in place. You don't see a lot of destruction of the cortex. This is a classic corduroy appearance. If you see it on the sagittal images, it will often look like these vertical stripes, like jail bars or something like that, or like corduroy cloth. And so that's typical for a hemangioma. This third lesion turns out to be a giant cell tumor. Again, you see lytic destruction of the bone, but unlike this first case, the margins are a little bit more well defined. You're probably looking at a lesion that's been a little bit more indolent, that's perhaps been there a little bit longer, and this turned out to be a giant cell tumor. Finally, this fourth CT image that we see, you see a lot of dense bone here. A feature that you might see is thickening of the cortex here, thickening of the cortex in other locations with bone deposition. This is Paget's disease, and so new bone formation, thickening of the cortex, those are characteristic of Paget's disease. So think about on CT if this pattern can help you refine your differential diagnosis. However, you're not always going to be able to tell, and as I said, you may have to resort to biopsy or surgical resection to actually get the final diagnosis. So our third case here is a 34-year-old woman with back pain and paresthesias. You have, again, a couple of MR images through that region. So what you see is you have a lesion here. This is a T2. You have this T2 kind of hyperintense to muscle lesion. You have some dark areas in the center where there's it's kind of markedly hypointense. On your T1 pre-contrast, you see that this same lesion is isointense to the adjacent muscle in the marrow. Again, low intensity signal areas in between. When you give contrast, those low intensity T1 regions enhance pretty avidly. They enhance more than the adjacent muscle. So you have an enhancing mass. It looks like it's centered in the posterior elements of the cervicothoracic junction. Again, we're looking at maybe a bone lesion. Let's think about looking at a CT. So here are some images from the CT. We've got a couple of axial images. This is kind of a higher image with a bone window. What you see is some posterior elements here. You see marked thickening of the lamina and transverse process. You see some new bone formation probably here, or bone deposition. If you come to a little bit different location in that lesion, you see there are areas of bone destruction with a soft tissue component coming out here. So you've got a mix of bone deposition, destruction, and soft tissue mass. So we think we're probably looking at an aggressive lesion. We see this new bone formation, and anytime we see new bone formation, we should be thinking about, is it a bone lesion? This looks like osteoid matrix because it's got that fluffy kind of cloud-like component, doesn't have the characteristic arcs and rings that you see of chondrosarcoma. This on biopsy turned out to be an osteosarcoma. Now let's talk for a second about differentiating insufficiency in pathologic fractures. This is a 67-year-old man with back pain and chronic osteoporosis. What you see here in the lumbar spine, you have a vertebral body that's lost vertebral body height. Here on T1, you've kind of lost the normal marrow signal. It's hard even to differentiate the bone from the surrounding disc. On T2, that vertebral body is pretty bright, so you've got some edema in the vertebral body. Maybe you have a little linear fluid cleft in there, which can be a good sign that you have that you're dealing with an insufficiency fracture. But if you do diffusion imaging, so C and D are DWI and ADC imaging, and what you see here is on diffusion, there's no abnormal signal within the vertebral body. This is very helpful because we're probably not dealing with a dense cellular process. We're probably dealing with just edema from a fracture. This case, on the other hand, shows a couple of fractures at the thoracolumbar junction, and it looks a little bit different. You see on T1, the marrow has been replaced in a lot of these vertebral bodies, but particularly in these two vertebral bodies that have compression fractures. On T2, with fat saturation, you see a lot of edema in the vertebral bodies, maybe some abnormal signal in the adjacent disc, but it's really hard to tell if that's a hematoma or just edema. But what you see here posteriorly is you have bowing of the posterior cortex back into the spinal canal. This is a very concerning sign that you're dealing with an infiltrative process that's replaced the vertebral body. Unlike that previous case, if you do diffusion imaging, what you'll find is those vertebral bodies have abnormal signal within them. So you see diffusion hyperintensity there. On ADC, it's dark. That's the cellular material of tumor. This is a metastatic melanoma with pathologic fractures. So this is a little bit of a summary here of how you might differentiate benign insufficiency fractures from malignant pathologic fractures. The benign fractures, when they're chronic, they tend to be T1 hypertense, so they do have some normal marrow still left in them. They may have a paraspinal hematoma, but it tends to be smaller. The posterior corner may bulge into the thecal sac, so you get a little bulge there, causing a little bit of narrowing of the thecal sac, but a diffusion, they tend to be negative. Malignant lesions are more likely to involve the pedicles and posterior elements. They're more likely to have an associated paraspinal mass. That bulging of the vertebral body and diffusion positivity we saw on the previous slide are definitely important and can clue you in. You can also look for disease elsewhere in the body. So if you have other lesions elsewhere in the spine, you have lesions in the pelvis, you might look for those with studies such as a PET-CT or bone scan, which can be quite helpful. This is a case of diffuse leukemia. This is a patient, you see a T1 image. You see the T1 marrow should typically be brighter than the disc. This is very similar to or a little bit darker than the disc. If you don't have your normal marrow, if you do diffusion on this, what you'll see is that the marrow has been diffusely replaced. So you have cellular stuff in the marrow, and it's almost all of the vertebral bodies here. This can be challenging to see when it's very diffuse. Sometimes you'll see this appearance in people with chronic anemia, but if you do see this, you want to think about, does the patient have an infiltrative process or diffuse systemic process which is causing this to happen? Diffusion can help you see if there's cellular abnormalities in the marrow, or if it's very cellular, to increase your level of suspicion for a systemic process. Let's talk for a second about what happens when you get tumor in the epidural space, particularly the ventral epidural space. If you take a look at a T2 image through a normal axial image through the lumbar spine near the conus, you see you have a normal thecal sac, you have this dark line of the dura. Here you have a disc here. If you have a patient with epidural tumor, what you may see is you may see bulging out of the ventral epidural space. You can see the dura here, but the dura is kind of tacked down in the center, and so it bulges out less. And what that eventually results in is you get an appearance that looks like curtains or drapes. So it's tacked down in the center, kind of bulging out like that. Very similar to drapes here in this one. It's called the curtain sign or drape sign, and you can see that pretty frequently when you have epidural tumor. Now, when you have epidural tumor, it doesn't have to remain confined to the ventral epidural space. Here you see a patient with multiple myeloma. This is a post-contrast fat-saturated image. You see kind of abnormal marrow in the lower lumbar spine, but more importantly, you have enhancement in this L1 or T12 vertebral body. And you see epidural enhancement extending away from that vertebral body. And then in the dorsal dura, you see this nodular kind of lumpy enhancement. On your axial images, this is a T2. You see lumpy thickening surrounding the dura. And on post-contrast, you see enhancement of the bone, a soft tissue component extending beyond the bone, both outside of the spinal canal and inside of the spinal canal. And it's going circumferentially around the spinal canal. So this is the appearance of circumferential tumor in the epidural space. Here we have another case here. This is a 55-year-old with neck pain radiating to the shoulders. You have a T2 image from the cervical spine a little bit to the side of the midline. Here you see a T2 hyperintense mass. Looks like it's maybe centered around neural foramen, extending beyond the bones themselves. On T1, similar to the other lesions we've seen, iso-intense to the adjacent muscle, very lobular. On this fat-saturated post-contrast image, we see very avid and homogeneous enhancement, this lobular region centered just to the side of the vertebral bodies. Our axial images confirm we have this big lobulated looking mass. It's coming into the prevertebral spaces here, going around near the carotid space, and you see involvement of the epidural space here. coming out of the bone, both posteriorly and anteriorly, and some involvement posteriorly here. This is a T2 image. Here's a T1 showing it's pretty iso-intense to muscle, hard to even see the boundaries. On this post-contrast, again, you see some enhancement. It's a little bit harder to see the enhancement than it was on those sagittal images, just because of the technique. If you do diffusion-weighted imaging through this lesion, what you see is very avid reduced diffusion, so it's extremely bright on DWI, so you're probably dealing with a very cellular, dense tumor. This turns out to be a chordoma. Chordomas are notochordal remnant tumors. They can occur anywhere along the location of the embryonal notochord, which goes all the way from the clivus through the central portions of the spinal canal, all the way down the spine to the sacrum. They can have kind of variable enhancement. They tend to be relatively large with relatively low symptoms. The most common locations are in the sacrum, followed by the clivus, and then in the mobile spine, as we saw in this case. So think about that if you see a lesion, particularly if it's very T2 bright. T2 hyperintensity is a classic characteristic of chordomas. Now, when you have long segment extradural lesions, such as these three cases here, these are three different patients with dorsal extradural lesions. You see this one, these are all T2 weighted images. So you see the dura is lifted up, you have a rounded lesion. They're all somewhat heterogeneous, have a kind of thick margins. This one perhaps looks the most heterogeneous of all, but they look very similar and it can be challenging to differentiate them, particularly on these T2 weighted images. When you see that, think about the enhancement pattern. And so here we see post-contrast images from all of these patients. We see the first one, you have enhancement around the periphery, but also solid enhancement centrally. When you see that, think about a tumor. Tumors tend to have more solid enhancement and more central enhancement. Contrast that to this second case here, where you see enhancement predominantly around the periphery. So it's mostly in surrounding regions, maybe a little bit of linear enhancement centrally, but nothing solid looking. This is a classic appearance of an abscess, which will mostly have peripheral enhancement. Now in this last case, what we see is very little enhancement at all. Maybe a little bit of central T1 hyperintensity, but it looks pretty similar to the spinal cord. This is more classic for hematoma, so early hematomas particularly don't tend to have very much enhancement. The enhancement pattern, like I said, is key, and it really helps you differentiate these lesions and give a better differential than you would have without the enhancement pattern. Case number 5 here is a 58-year-old man. He had a fall 18 months ago. Now he has worsening myelopathy and is wheelchair bound. So there's some really key triggers here in this history that should kind of raise your hairs a little bit. It's an older gentleman. He's had a progressive myelopathy over a longer period of time. Now when we image his spine, what we see is a long segment T2 abnormality in the thoracic spine here. The cord is a little bit expanded and definitely looks edematous there. When you give contrast, maybe there's a little bit of hazy enhancement there, but not too much. But one key feature that should concern you a little bit is the little squiggly abnormalities along the outside of the cord. Maybe you make them out on T2 as well, but that's a little bit concerning that there's vessels there and that you're dealing with a vascular abnormality. This is just some images from lower in this patient. Again, T2 images through the conus. On these images, you see that the conus itself is actually enhancing much more avidly. So you actually see some enhancement of the conus there. The conus itself on T2 axial images is very expanded, T2 hyperintense centrally. This is the classic appearance of a spinal AV fistula and the classic clinical presentation in an older gentleman. Here you see some images from an angiogram. So this is an angiogram with an injection into a lower thoracic radicular artery. What you see is the radicular artery filling here, and then abnormal veins centrally within the middle of the spinal canal. If you zoom out a little bit, what you see is markedly abnormal vessels throughout the entire spinal canal, going all the way from the clavicles down into the pelvis here. And these are markedly distended veins. Now the pathology here is an abnormal connection along a nerve root sleeve where an artery is directly connected to a vein. It leads to venous congestion and these abnormal veins that are exposed to arterial pressures and edema within the cord. Like I said, these are classic in elderly men with a progressive myelopathy. They tend to have a long delay to diagnosis, like of a year or more. Many of them have had prior surgery. You want to think about this anytime you see long segment cord edema and in a patient that has progressive weakness, particularly if you see what looks like curvilinear enhancement around the margins or dilated vessels. Now, that abnormal enhancement of the cord is just a result of the congestive myelopathy. Now, the pathology there, as I said, is an AV fistula along the nerve root sleeve. The treatment for those is to either embolize them, so in angiography to go in and put embolic material in there, or to go in and do surgery and ligate that abnormal connection. Now, it's very important to identify this because it stops the progression of disease and the patients can have recovery of function over time. It doesn't always recover, but it's important to find it. Extradural case number 6, we have a 71-year-old man with slowly progressive back pain. Here you see a T2 weighted image with, again, in the dorsal epidural space, a lesion which is kind of T2 intermediate, a little bit darker than CSF. If you do fat suppression, you see, again, the majority of it is bright, but perhaps centrally it may have some areas which aren't as bright. This is a T1, the pre-contrast T1, so we know we're looking at a pre-contrast because that venous plexus is not enhancing there. And we see it's pretty bright on T1 pre-contrast, which is a little bit unusual. There aren't that many things that are bright on T1 pre-contrast. Here we see the post-contrast image. That lesion is probably enhancing some in addition to its intrinsic T1 hyperintensity. This is a case of an angiolipoma. Angiolipomas are rare and benign collections of both fatty and vascular elements. They will have fat density on CT. And so if you go back, like you can see, that's what's causing this T1 hyperintensity here and probably causing it to partially suppress on our fat suppression. These are most common in thoracic region. They are slowly progressive, so even though they're benign, they can get larger over time and ultimately cause compressive symptoms. Most commonly, they extend over more than 2 vertebral bodies. Here you see an example of a little bit smaller one indenting the dorsal thecal sac at the thoracolumbar junction. In summary, we've taken a look at a lot of extradural lesions. We have to keep in mind that the whole world is extradural, so anything that's not in the thecal sac is extradural. This includes the discs, bone, meninges, nerves, and blood vessels. But think about the things that are the most common, right? Disc protrusions and disc abnormalities are very common, particularly in patients that have progressive degenerative disease or a lot of other degenerative disease. Metastases are very common in the bones, particularly you think about prostate cancer, breast cancer, the common ones. Infection is very common as well. So if you see a patient that has a fever, sepsis, or circulating, bacteremia, think about whether you have infection like a discitis, osteomyelitis. Remember this classic appearance of extradural lesions. I want to say thanks to everyone for tuning in today. For our next lecture, we're going to finish up the spine tumors series, talking about cystic lesions, give you a little bit of summary of spine tumors. If you haven't checked out the rest of the lectures, be sure to tune in and check those out. Go back and check out the lectures on intramedullary lesions, intradural extramedullary lesions, and kind of an overview of spine lesions. Be sure to check out the rest of the channel and the rest of the content at learnneuroRadiology.com. Thanks, and be sure to like and subscribe to the video.